Hello everyone, this is Dr. Bilal. Welcome to Wow Trauma Talk Season 2, Episode 1. Today we will discuss IU access with Dr. Amar Pyari Makhanlal Chauhan, who is an emergency physician and medical innovator. And he has designed IU access power driver and needles in India. So please tell us, sir, IU access and your experience with it.
Okay, thank you, Dr. Bilal. IU access means intraosseous access. That precisely means placing a needle inside the bone marrow through a drilling process. And this is basically used in a difficult vascular access scenario when patient is having life-threatening emergency and we are not able to get peripheral IV access, and we have given already 2 attempts. So basically it is a simple life-saving skill, and as far as my experience is concerned, I can vividly recollect a girl child, approximately 5-year-old, who came to me few years back with dengue hemorrhagic fever, and she was in shock. So we tried placing a peripheral vascular access, but we were not successful. Then ultimately, I put a tibial IO, and let me tell you, Bilal, that not only we gave her fluid, but we were able to give even platelet transfusion also, and that child was saved. So in my experience, it is a very simple, doable, life-saving skill.
So what about its history of IU access and current scenario in India?
So as far as history goes, Dr. Drinker is a Harvard physician who in 1922 conceptualized the concept of IO access, and it was Dr. Ticontis who demonstrated infusion in the bone marrow, and actually it is not being done in India in a very widespread manner, and that's what precisely we have designed the IO access power driver and needle, because it is a doable skill, as I told earlier, and it is simple to perform. Even paramedics can perform. So in current scenario, IO is being not done in India, and there's a lot of misconception. And one of the main misconception is that it is a pediatric, rescue vascular access skill, which is not. It is as effective in adult as it is in pediatrics. So we have even adult, IO access mannequin and power driver, and our aim is to make this skill popular and widespread in India.
So can you tell us about anatomy and physiology, about IU access?
Okay. So as we know from our, understanding of basic knowledge in medicine, basically bone marrow is a compact tissue, and it communicates with systemic circulation with the Haversian and Walkman canal. And for example, the tibial IO basically, or the tibial bone marrow, communicate with the popliteal vein, and the humeral bone marrow communicate with the axillary vein. So basically the bone marrow is connected with the systemic circulation, and this is why when we give medicine or fluid through IO access, it reaches heart, I can say, and there evidence that it reaches heart as early as in 10 seconds.
So please tell us different sites and which one site is better than other.
Okay, that's a very important question, and the sites I think most commonly being used is proximal tibia, but you can do in distal tibia also and proximal humerus. These are in adults, when in children you can have this IO access in distal femur as well. But let me tell you, as I was talking about the background, the IO started in sternum, and during the Second World War, lot of, I would say thousands of soldiers were saved with the IO access device. But later on we forgot about it because of the development of the central line catheters and other devices. But again, back I think since 1980s, the interest has been renewed because we are living longer, and in older patients we are having difficulty in getting vascular access. So now again the IU access is in vogue, and it is being done routinely in Western countries. And as far as size is concerned, the humerus is definitely has certain advantage because it is closer to the heart, and the flow rate, if I talk about the flow rate, it is maximum in the humerus, it is to the tune of 30 liter per hour, whereas in tibia it is 6 liter per hour, and distal femur it is 8 liter. And one more advantage of placing humeral IO is that it is in non-dependent bone, so it causes less discomfort. And as I told earlier, that it is close to the heart, so the medication reaches heart in a very fast manner. So these are the site where we can place IO access.
So, sir, please tell us about the procedure and silent features.
Okay, so that's one thing I would like everybody to master in India. So the procedure is essentially, it's a very simple, and once you have decided to do an IO and you have selected the site, if the patient is conscious, you give local anesthesia. And first, I would say for the novice or for the beginner, you go for tibial IO access, and that is the proximal part. Why we choose proximal and distal tibia? Because the cortex there is thin and there is a lot of cancellous spongy bone, so that help us in drilling procedure. So once we have selected the site, I'll talk about the proximal tibia, and patient we have anesthetized the local area. So we go at an angle of 90 degree and just drill inside with a slight pressure applying on the power driver, and once you get giveaway feeling, you stop there, you remove the the stellate of the needle, and then you aspirate slowly. But sometime you don't get aspirate, like in case of severe dehydration or in case of shock. Then what you should do, basically you should push 5 ml of saline, and if you don't encounter any resistance, then I think you are in the right place and you can start your infusion.
Sir, can you tell us why only IO access? Why not center line?
Yes, and this is the question which is asked very frequently, because whenever I promote or discuss IO access, people will start bringing this central line. But I must tell you, central line will take at least 10 or 15 minutes to set your equipments or to get your supply, where IO access is a very simple, and it is like it doesn't take much time. It takes only, say, I would say in my experience, because I do IO routinely, it takes hardly for me to do IO like just 30 seconds. So there is a time factor, and when sick patient comes, we definitely want to resuscitate them as early as possible. So it is not only the time taken in IO access is very, very less, and secondly, the first pass success. Like when you do IO access, then I think first pass success rate is 90%, whereas if you compare the central line, it is like 60%. So these are the two advantages we have with IO access. Number one is the lesser time, and the second is like the first pass success. And let me tell you, sometime patient comes and you are trying to intubate. There also you can put an IO if you have difficulty in getting vascular access. And there are reports, and in fact there are cases where RSI has been done by putting IO and giving medication through the IO system. Okay.
Right. So one more question is, sir, can one patient, the same patient can have one or two IO access at the same time?
Oh, certainly. One patient can have multiple IO, because see, when patient of polytrauma with hemorrhagic shock, then we can definitely put more than one IO. I can say that one can use a tibial IO and a humeral IO. So only precautions with the humeral IO is that when you have put humeral IO, you should not abduct the arm, because when the needle gets stuck with the shoulder joint, and it can get dislodged sometime. So you have to be careful that you should not abduct the arm when you put a humeral IO.
Okay. So what are the medicine that we can go through IO access line?
Okay, so anything you can give through the peripheral venous line, you can give through the IO access. Like you can give all kind of medication, you can give vasopressor, you can give thrombolytic agent, and you can give blend and blood product also. And not only this, you can, like the aspirate, you can send for the lab also, because the value of the IO access aspirate and the blood, they are almost similar. So there also you can have some help, You can send the blood, the aspirate which you have aspirated from the IO needle. You can send for labs also.
So how long we can keep the IU access there in the site? And a period, time period.
Okay, so that's very frequent question, and people have a lot of misconception about it, because some I have heard, and let me clear that you can keep IU access for 24 hour maximum, but as soon as you have your venous bed filled up, or you can have other kind of vascular access like central line, because after I think you have resuscitated the patient, you have some time with you, and you can put central line. So you should try putting a central line after 6 to 8 hours. But let me tell you again, you can have IO access in the body up to 24 hours. And whenever you are giving medication, I would like to mention here that you have to use some kind of pressure device also, because bone marrow is a compact tissue and you need some pressure to open it up.
Yeah. Sir, is there any advantage between various sites, like one site or the other site is better than that?
Oh yes, certainly. As I discussed earlier, the humeral IO is having maximum flow, and certain advantages like it is less discomfortable, and since it is in a non-bearing bone, so it is less painful, and it's near to heart. So definitely whenever you have opportunity and you have the skill, because I think in my opinion doing humeral IO is slightly difficult as compared to tibial, but whenever you have expertise, then definitely you should go for humeral IO, or when you need more than one IO access.
Okay. Sir, last question, please. So, what are the complications and how frequently they can occur?
Okay, that's I think one question which haunt many of our beginner, because they think by putting IO we are going to increase infection rate, which is certainly not the case. The complications are very few. The first and foremost complication is the extravasation of fluid, right? Your needle can get dislodged and the fluid can get extravasated. So for that's a squeeze test. So whenever you start with the infusion, you can just squeeze the calf, and if the infusion stops, then it is outside the bone, and you should try some other side. But if it is like by squeezing test, if it is not stopping, then it is in the right place. So extravasation of the fluid. Number two can be compartment syndrome. If it goes undetected, then there can be, of course, with any other skill, there can be infection, there can be fracture also, and of course patient discomfort. There could be broken needle, dislodged needle, and but if you look at the scenario, because scenario here is like life threatening, this is like the situation where we have to put IO access when we are not able to get peripheral IV access or central line in a timely manner. So if you compare that scenario with these complications, this is, I would say, very minute, and they happen in less than 1% of cases. So overall it is a very safe procedure, and one must not worry about these complications. And only contraindication of this procedure is like if you reverse IO, that is OI, it is osteogenesis imperfecta, like the brittle bone syndrome. If somebody have that, then you don't attempt IO access.
So thank you, sir. Thank you very much to have you here to explain the new technology that you have designed actually. So we would like to hear again from you in the next time. Till then, it's goodbye.
Thank you very much.